Good morning, all. Today we'll be discussing about the errors in cavity preparation. During the root canal treatment, the mishaps can happen in any stage, whether it's from the beginning access cavity preparation or the diagnosis itself by treating the wrong tooth, and then followed by cleaning and shaping, obturation, or missed canals in the initial stage. The errors can happen at any time. In last session, we have discussed about the principles of access cavity preparation. Now we'll see if we don't follow the principles properly, what are the various errors that can commonly occur in the endodontic access cavity preparation. The first one is access cavity in wrong place. Irrespective of where the caries is there, whether it's gingival or in a class 5 lesion involving pulp or a proximal lesion which is involving the pulp, irrespective of which region the caries is, you are supposed to do the access cavity only from the lingual surface in anteriors and occlusal aspect in the posterior teeth. There are exceptions, but most of the cases we are supposed to do in this direction. Suppose if any caries is there in the proximal side, and if you make an access opening from the proximal side, it will be difficult for you to navigate up to the apex and do the instrumentation. So instrument separation, ledges, all this, and incomplete cleaning and shaping. So all this follow this wrong access cavity preparation. So ideally what you're supposed to do is remove the caries, excavate it completely, and then restore with a composite or GIC. And then continue with the ideal endodontic access cavity preparation, that is lingual surface of the anteriors and occlusal surface of the posteriors. Next is access cavity being too small. See, it's good to be conservative, but too much conservative cavity can cause certain errors. One such thing is one of our objective, we already know that it is to reach till the apex of the tooth so as to do the cleaning and shaping and obturation correctly. So you won't be able to take your instrument up to the apex since there is obstruction from different areas of the access cavity itself. And it might cause ledges or even perforations or canal transportations, or even the instrument can also separate if you try to force the instrument up to the apex. And there can be discoloration also if the access cavity is too small, not having sufficient incisal extension or gingival extension. There can be pulp tissues which can remain inside this pulp horns, and then this can cause the discoloration of the crown later, even if you have completed the root canal treatment. So access cavity has to be conservative, but not too small to cause errors. A small access cavity can also cause missed canals. In this case, you can see that by making a very small opening, we can get the labial canal, but the lingual canal is missed itself. So this can happen in the posteriors also. So make the adequate extension. Gauging. The burr, if you are not using in the right angulation, or if you haven't observed the preoperative radiograph properly, then you might end up doing the gauging, or if you extend it without noticing, from gauging, you can even extend to the perforation stage. One, when we are observing the preoperative radiograph, notice whether any tilt of the crown or root is there. If it is there, accordingly, you have to change the angulation of your burr. If not, you might create false anatomical or dentinal wall like this, which is called as gauging. And also there are general principles that in 45 degree, you have to start in the anteriors and then followed by changing the angulation to long axis of the burr, long axis of the tooth. So if you don't change the burr angulation correctly, and if you continue to do in the 45 degree, you might end up in perforation. Like in the next picture, you can see. You have started the cavity in the 45 degree, and if you continue to do it without changing the angulation to long axis of the tooth, then you might end up doing perforation in the opposite wall labially. Even in a molar also same thing can happen. In a preoperative radiograph, you're supposed to see where the roof is and where the floor of the access cavity is. Accordingly, you should increase your depth of the cavity. If not, you might not get the burr drop effect, so-called burr drop effect, and you might end up in perforation. perforation occurring because you have not observed the tilt of the tooth. Now the root of the tooth is little bit tilted. There is a mesial tilt of the crown as well as distal tilt of the root. But without observing it, if you just follow the principle of going along the long axis, you might end up doing a perforation or gauging in the mesial wall. Same thing, failure to observe the mesial tilt of the tooth and you're doing a perforation in the mesial wall of the tooth. Overextended preparation. If you don't observe the radiograph properly, sometimes receded pulp or calcified pulp you might miss, and then in search of the canal, you might end up doing a big cavity like this. Not having enough knowledge about the pulp space anatomy also can cause extended cavity preparation. So this, even if you do a successful root canal treatment after finding out the canals in such cases, ultimately the result will be a failure because so much of tooth structure is already compromised. And even if you put a crown after this root canal treatment, it might cause fracture of the tooth and you might end up in the failure of the case. So have the right knowledge and observe the preoperative radiograph. Observe the tooth also clinically so as to do the right access opening. And this is the first step of the root canal treatment. So if you do this step wrong, then it can lead to even mistakes in the cleaning and shaping as well as obturation of the canal. So make sure the first step of the root canal treatment you are doing correctly. So the best way to handle these problems is to prevent them from occurring by having the good theory knowledge about the pulse space anatomy as well as the principles of the access cavity preparation, having the right armamentarium, and observation of the tooth as well as the radiograph. Thank you.